Hi everyone, I'm Dr. Santosh, Consultant Emergency Physician, Yashoda Hospitals, Secunderabad, Academic in Charge here. In our program, Experts Appraisal in Emergency Medicine, today we are going to have a detailed discussion on airway anatomy in infants and its significance in ED. Today we have Dr. Jovin Antony, pediatrician from pediatrician is an assistant professor from CMC Vellore. Today he will discuss in detail regarding this important topic. Hello, Dr. Jovin. Welcome to our program. Can you please take over?
Thank you, sir. Sir, is my slides visible, sir? Slide share?
Yes, they are visible.
It's in the slideshow mode only, right?
Yes.
Yeah. Sure. So today we'll be presenting on airway anatomy in an infant and its significance in emergency department. So we'll be discussing about why this topic is relevant and the anatomical and physiological considerations regarding airway in an infant, the evaluation of airway in an infant, management of normal and an abnormal airway, a little bit a note on difficult airway and certain case scenarios, just to make things interesting and just to re-emphasize. So mostly I'm sticking to airway related topics because though a lot of breathing, ventilation regarding topics are also having similar implications, I'm not going there because of the want of time. So when we talk about the pediatric airway, it's very important because most of the pediatric arrests, about 80%, they are because of respiratory origin. Majority of these, they are in infants. And why is that everybody is taking a pediatric intubation or a sick child as a challenge? It's because the baby as such is small and the mouth and the organs inside are even smaller. And we need particular specific sizes instruments for that. And also there is a significant anatomical and physiological differences. And so there is definitely a highly prevalent anxiety among a lot of our adult practitioners. So if you look at it, children are at increased risk for peri-procedural laryngospasm, and that can result in bradycardia, hypoxic arrest. So airway obstruction can happen from various infectious causes like say croup, epiglottitis, and also non-infectious etiology like foreign bodies. So difficult intubation, esophageal intubation are also very common, mainly because we might not have taken into consideration the anatomical and physiological differences, and also depending upon the equipment available and the personal related issues, depending upon their skill, experience, the final result may vary. And also they are also a higher risk for aspiration. So as we see over the decade, we have seen that there is an increasing over dependence on super specialists like pediatric intensivist, pediatric anesthesiologist, or a pediatric emergency physician when it comes to handling a pediatric airway. And what essentially is happening is that in smaller centers, this basically deprives the routine practitioners from taking care of ill children. And so when somebody comes at the moment where they need that care the most, they may not be able to give that care, which is why we want to talk about this today. So
Doctor, is your screen on full screen mode?
Yes, sir.
Okay, I'm not getting 100% screen stretch. Okay, go ahead.
So considering certain anatomical considerations, so this is just a normal airway anatomy. This, is my mouse cursor visible, sir?
Yes.
Yeah. So we have the nasal cavity, the oral cavity with the tongue. The behind the nasal cavity, it leads to the nasopharynx, the oropharynx, and both finally lead into the area behind the larynx. So that's the laryngopharynx. So the area in front is basically your airway, and this is the laryngopharynx, and from there on it goes into the esophagus. So we have the larynx, and so we'll have to little bit more concentrate on the airway. So this is just AP and sagittal views of your airway. So we have most importantly the cartilages are the thyroid cartilage and the cricoid cartilage. So we have a hyoid bone and there is a thyrohyoid ligament. And when we look it up from posteriorly, we can see that's the epiglottis and we have the arytenoid cartilages. and also corniculate cuneiform cartilage, which is seen in the sagittal view. So this is regarding the main airway. So having noted that, we'll see how it looks from an intubation point of view. So once we go into the larynx with the laryngoscope, this is what we essentially see. So we have the epiglottis. So anterior to the epiglottis, you would actually be having the vallicula and the tongue beyond that. So we have the epiglottis and the array-epiglottic fold, and we have the folds. As we go beyond towards the caudally, we can have that there is a false fold, false vocal fold, and there is a true vocal cord. Okay, so this is the anatomy, and you see that beyond that there is a cricoid cartilage, and then there is tracheal rings that start visible from there. So this is what we see in the intubation. So just to talk about why infant and adult airway anatomy is different. So if you look at it here, this is a picture which is overlapping a smaller baby's airway with the adult one. So you can see that the nostrils, they are very narrow. And especially when it comes to newborn children, they are very obligate nasal breathers. So any obstruction can cause significant hypoxia. Also, infants and toddlers, they tend to have a more rounded occiput. Also, this is the worst when it comes to newborn, because they might have a capute which is almost, which will resolve in a week's time. And so it is worse in case of newborn, then it goes to infants, and by the time they cross that toddler stage, it becomes moreover flatter. And so we have a larger tongue for the oral cavity. So there is very less space in the oral cavity to see the structures beyond when we are starting for an intubation. So we can also see that here the epiglottis. The epiglottis is more lofty in an infant, and it is more omega shaped. And larynx is very high up compared to adult larynx. And vocal cords, if you look at it, they are more aligned slantly, anteriorly but slantly. However, it is more of perpendicular in case of adults. And the neck is also quite short. And we know that the cricoid ring in children happens to be the narrowest part. However, in adults, it is basically the level of the vocal cords. So this is a table that summarizes what happens at the differences and what are the risks. So because of the narrow nostrils, nasal obstruction can cause significant respiratory distress. Example is bilateral choanal atresia can present with central and peripheral cyanosis, and that can be detrimental if not addressed early. So occiput is large and round, and it is because of that, when the baby is lying supine, that can obstruct the larynx if the baby is not very that can obstruct because the occiput flexes the head forward, and also that causes the tongue to again king the airway. So that is one thing, and the tongue is quite large, so that can obstruct. Laryngeal and tracheal cartilages, they are very easily compressible. Because of that, there can be an excessive flexion or extension. This can cause external pressure of the larynx and can obstruction of airway. And when we have larynx which is very high, what happens is that the tongue and soft tissue can easily obstruct the larynx. So cricoid ring, which is narrower in children, and in adults, it is the level of the vocal cords. So because of that, pediatric or the infant airway is more of funnel shaped. And the other one in the adults, it is not like that. So what happens is, because the tube bypasses the vocal cords and enters this narrower part, there is a higher chance for subglottic edema. And also, whenever there is some infections like croup, there is excessive edema at that point, and that can cause more intense stridor. Then there is laryngeal and tracheal diameter, which is narrow, which means that minimal edema can cause more significant obstruction and resistance to the airway. Again, the neck is short. So because of that, any sort of flexion that can basically cause more obstruction, and the infant's chin can rest on the chest, reaching the second rib. So the hyoid also will overlap the thyroid cartilage. So basically, it will be very difficult to identify the various landmarks. Then trachea is also short. Adenoids and tonsils are seen in pediatric age group. So they can also cause obstruction. So adenoids in case of significant issues that can be causing in nasopharyngeal intubations, and tonsils when it comes to even oral intubations. So also babies can have loose tooth. This is just an picture showing bilateral kissing tonsils. So hardly there is any space that you can see. But however, having said that, we know that because the larynx is quite high up, we can see the epiglottis here. And even the vocal cords, if you can clearly see that. So this is basically the larynx and trachea in an infant. So this is when the child's head is in extreme flexion. So that basically causes the tongue to obstruct the airway. So the tongue will also compress the laryngeal and tracheal apparatus. And when there is extreme extension, even the anterior structures can cause further compression. So in both cases, the airway is significantly narrowed. In pediatrics, we know that the laryngeal apparatus basically descends from the brachial arches. So the pediatric or the infantile airway, so in that it is basically the neck is at the C2, C3 level. So it is the larynx is at C2, C3 level here. But however, in an adult, it reaches by C4 to 5, C4, C5 level. This is because there is a differential growth of the bones there and the soft tissues compared to the mucosal structures. So infants can also have more anteriorly placed larynx, which can make visualization during intubation quite difficult. So in an infant, there is a large head which is relative to the body size. It's a rounded occiput, large tongue, and there is a larynx which is positioned higher in the neck. All this can cause significant obstruction if the child's head is flexed forward. And especially if the child is not conscious enough, then again that can cause automatic flexion and cause airway obstruction. So the laryngeal and tracheal cartilages are soft and easily compressed. So we can see that many a times we have seen here in our setups also that we get calls from wards that during an LP procedure, the staff or the person who is assisting would have flexed the neck quite badly so that they go into hypoxic arrest. So regarding the larger trunk, it obstructs the airway and which makes it worse when these kids are exclusively nasal breathers. So it is difficult to visualize the larynx when there is hardly any space there. And because of this, there is a recommendation that we use straight blades, which can basically elevate the epiglottis. So that is preferred in infants and toddlers. And also the angle vocal cords. So what happens is if somebody has to do a nasopharyngeal intubation, the tube can come in from there, but because it is a blind kind of a procedure, the tube, what happens is it goes and rests at the anterior commissure there, instead of going in like that into the airway. So that can cause significant issues. You may not be able to ventilate the child. So this is basically how it looks, the epiglottis looks in an infant. Very quietly, it is an omega-shaped epiglottis, quite floppy. And we are not able to clearly see the vocal cords there. And in a toddler, it is still omega-shaped, but however, the visualization is more easier. And in adults, it's becoming more of a spade shape and nice V-shaped vocal cords, both sides we can see, including the tracheal rings beyond that. So this is just a change in the shape of the epiglottis. So definitely the floppier epiglottis means we need to lift the epiglottis using a straight blade. So again, as we told, this is the funnel-shaped airway. So in infant, what happens is the narrowest part is at the level of the cricoid. So that means there can be more edema, especially in conditions like croup. Also a tight-fitting ET endotracheal tube can cause significant edema, and subglottic stenosis can be seen, especially in case of prolonged ventilation. So there is a preference for uncuffed endotracheal tube, especially in younger children. And adult type cricoid is developing almost by 10 to 12 years of age. Just coming on to the physiological consideration. So here we have an infant's airway, the trachea, and an adult's trachea. So you see that the diameter 4 mm, here is 8 mm. So if there is a circumferential edema of 1 mm, the diameter here reduces, the internal diameter reduces to 2. Here it's 6, which basically causes significant reduction in the cross-sectional area in case of the infant. However, in adults, that's not the same. That's not the case. The resistance to the airway, the air passage also increases so much because it is 2 times 2 to the power 4. So 16 times increased resistance happens. So this we get from the Poiseuille's equation. So the resistance or the flow is basically inversely proportionate to the 4th power of radius. Also, infants and toddlers, these children, they are quite inert and inactive. They mostly only sleep. So most of the time, their parasympathetic tone is more active, and also the myelination is still incomplete, and they have underdeveloped respiratory center, and also the behavioral responses that happens to various stimuli are also different. So because of which there is an increased risk of airway complications and respiratory failure. So how does an immature nervous system predispose to hypoxia? So if you look at it, a child has a predominant parasympathetic tone, an infant. So that causes more hypoxia, and so that hypoxia is causing mostly bradycardia. So if you look at it in an adult, a hypoxic stimulus will cause usually tachycardia. So instead of tachycardia, so when the tachycardia comes, the heart rate will basically increase. There will be more cardiac output, and because of which there will be the tissue hypoxia state might resolve. But when there is bradycardia, when you see in an adult, that means it's almost very late, and that's like an imminent cardiac arrest state. But that's not the case in pediatrics, because the sympathetic tone is not that developed compared to the parasympathetic tone. The instant response that we get is a bradycardia. So a bradycardia can cause hypotension, and it will cause also decrease in cardiac output that in turn leads to more hypoxia at the tissue level, more hypercardia, and more acidosis. That means there can be a faster cardiac arrest that can happen in hypoxic children. Also, children are quite scared. So they become very anxious, they cry. So because of that, there can be more secretions, and the irritability of the airway is more. There is a higher risk for laryngospasm, wheezing, and also airway edema. And we don't know whether these kids are crying because they have fear or they are actually in pain. So most of the time, there is a higher chance that they get over-sedated, because as such, their nervous system is incompletely myelinated, and also their blood-brain barrier is still immature. So because of which, the drugs can cross the blood-brain barrier faster and can cause significant respiratory depression. And there can also be in neonates and even in kids up to about 60 weeks of corrected gestational age, they can actually have apnea. And also the most common infections during the early infantile period, like pertussis, bronchiolitis with RSV, all this can also cause significant apneic episodes. And on top of that, they have also, because the prematurity of the respiratory centers and the respiratory drive, they can have apnea of prematurity. So all this can basically complicate and lead to a hypoxia in a child. So this is what I've already explained. Regarding the oversedation, that also we have already seen. Okay, so now we'll just come to assessment of airway. Sir, so far clear, sir? Hello, just a check, sir.
Yes, please.
Hello. Yeah. So coming on to the assessment of the airway. So it is always best to look the child from far, unless the child is quite sick. And so that avoids the anxiety in a not too sick child. And what all are we supposed to assess? First one is chest wall movement. So if the airway is patent, obviously we are able to ventilate the child, and so chest movement will be there. So chest rise would be there. So the PALS recommendation is that we look for minimum 10 seconds even in a sick child. At the same time, we can also do the pulse check. So the other thing we look for is breath sounds and any additional sounds which can come from the airway like stridor, snoring, gurgling, stutter, rattling. These are various upper airway sounds. And so based on the status, how clear the airway is and how maintainable that is, it can be either clear where the airway is open and unobstructed. Maintainable is where there might be an obstruction. However, that obstruction can be relieved by simple maneuvers. And non-maintainable, that is where the simple maneuvers fail and you have to have a definitive advanced airway. So what are the signs of upper airway obstruction? So when we have increased respiratory rate or an increased respiratory effort that we see with retractions. The retractions can be classified as substernal, subcausal retractions, intercausal retractions, and suprasternal retractions. And beyond that, when you see that the scalenea muscles are being used. There is nasal flaring. So the more we go from the chest towards your neck and face, that means more and more accessory muscles need to be used to maintain that airway. So that extra effort is there. So that is the significance of retractions. So there might be a problem, significant airway obstruction with more increased grade of retractions. There can be abnormal inspiratory sounds and episodes like there can be no air entry in spite of child breathing. So there can be like respiratory effort. You might see a chest rise, but there is hardly any air entry that we can see. So we can hear. So that means there is a almost near complete airway obstruction. This is just the Malakpet scale that is routinely used among anesthetists in emergency departments to assess what grade of an airway this is. So it basically looks at if you can see the soft palate, uvula, and only if just the hard palate. And you can see beyond that in the posterior pharyngeal wall. So that is a normal airway. You should be able to see the tonsils bilaterally. However, the visibility of the soft palate starts reducing when it comes to the class 2, and it is further less with uvula, tonsils, etc. not being seen in case of class 3. And when it class 4, we can only see the hard palate. So this is how we classify the airway. So airway assessment in ED is almost always clinical. So there are certain roles like in imaging. For example, we might look for an epiglot thumb steeple sign in case of a child with croup. So just to confirm, these are only going to confirm your etiology. So these are not going to give you the diagnosis just like that. So the diagnosis regarding any of the airway problems has to be made always clinical, because that makes a significant difference in the management. So there are certain roles, like I said, there can be roles for X-rays of the neck, which can be AP or lateral view, CT scan, MRI. All this has some life, but it should not be at the cost of this child's life. So all these radiographs can wait. First, it is very important to stabilize. So once you stabilize the airway, you know that there is no threat to the child's life. We can get these definite tertiary assessments done. And when it comes to children with airway issues, it's always important that somebody who is skilled enough to handle airway, difficult airway, accompanies them, so that on the way, on the trolley, in the X-ray room, if the child collapses, they will be able to manage. So adequate resuscitation equipments also should be sent along with the child. And intubation at any cost should not be postponed just to get diagnosis like X-rays, things like that. Also, many a times we do take ABG or multiple other invasive blood tests. That is also required for the diagnosis for further tertiary assessment. But however, these are quite painful. So most of the time what happens is, in a child with airway obstruction, the child will keep crying. That can cause more laryngospasm and that can worsen the airway obstruction. So coming to the airway management, the goals of airway management is to protect the airway, adequately ventilate, and adequately oxygenate. So there are certain simple measures. So we are talking about a maintainable airway here. So these are the measures that you can use to maintain airway. So first one is positioning. For a child who is very responsive, alert, who has just come with some stridor, some sort of distress, you can always assume the position of comfort for the child. That makes life a whole lot easier, and parents, the child's, everyone's anxiety is relieved. However, we are also able to pursue further with the treatment. Also, the other option is to elevate the head end of the bed. In an unresponsive child, if there is no cervical injury, we can use left lateral position. And if there is a cervical injury, you're thinking the best thing to do would be a jaw thrust. And head tilt and chin lift maneuver is not really used in the trauma setting. But that is used in unresponsive child. So at certain times, the tongue which is falling back, all that can be reversed by using these maneuvers. So the other option is when there is significant secretions, we can use suction. Also, if there are certain food particles or certain small semi-solids or foreign material, especially in case of trauma and all, if they have some blood and all in their mouth, we can always use Yonka suction. So whenever there is history of trauma, you can even anticipate things like tooth which are dislodged. So it's better to use a stronger suction, which is a little more wider bore, like Yonka suction, than just the routine wall suction. Then relief techniques in case of like a foreign body, like if the child is an infant, we can use like the back slaps with the chest thrust, or we can use abdominal thrust if the child is more than 1 year of age. Then obviously coming to the airway adjuncts, which can keep the airway patent, like the oropharyngeal airway, nasopharyngeal airway, etc. So this is just a diagram showing how the procedure is done in case of a relatively bigger child and in case of a infant. So if you see that the head tilt chin lift is actually done in case of a pediatric age group. So that causes to be in that sniffing position that aligns all the airway axis with the mouth and nose, that axis. So it because of this alignment, this position is safer there. But however, because of the various anatomical consideration that we had already discussed in infants, the head is mostly kept in neutral or maybe just slightly extended position. It's neither flexed nor too extended. So that is the way to that. So the jaw thrust is again given in children, especially in cases like trauma, that basically helps from the tongue from falling back. And this is basically a demonstration just to showing in hyperextension what happens. Again, the airway is obstructed. When there is excessive flexion, again, airway is obstruction. So the best thing to do is keep a shoulder roll just beneath the shoulders. That basically causes the chest to be at the level of the ear canal. So that is supposed to be the best position in case of infants. So as we keep on repeatedly saying, we have to avoid overextension, which causes occlusion of airways in infants. Extreme extension or flexion that can obstruct the airway, mainly as we discussed, relatively large occiput and a shorter neck, larynx high up. So if we use a pillow, what happens is it basically causes the head. If the pillow is kept under the head, it causes the head to bend forward over the chest. That causes the tongue to fall backward and it worsens the airway obstruction. It will also make it harder to lift the head back to open the airway. So when you are trying to actually intubate, something actually sitting beneath your occiput makes it even harder. So as we said, shoulder roll is what is recommended in infants. So oropharyngeal airway, if you're using an oropharyngeal airway, it should always be of the correct size. This is just a chart which shows the varying sizes. It's always available as in most of the emergency departments. These charts are displayed for people to see and use. So that is one thing. So here we see, if you choose the appropriate size airway, it helps. But if you say this is a airway, which is a oropharyngeal airway, which is smaller in size. So what internet does is basically goes and hits the tongue somewhere in the middle, so that whatever tongue is posterior to this airway, it basically goes and compresses over the epiglottis, further obstructing the airway. And if the airway is too long, what happens is that airway per se can go and press onto the epiglottis. So too small airway can also cause, if you're keeping it for so long, like in certain cases, we would like to keep like in status epilepticus, where we are expecting the child to wake up soon, but child is not woken up. There might be times when these oral airways are kept like that for a longer period. So this kind of an procedure, what can happen is the venous and the lymphatic drainage can also get occluded, and that can worsen the edema of the tongue. And the larger airways, basically they can also extend over the mouth, and that can make the mask seal difficult. So if you see, if there is a bigger airway, the outer portion, if it is quite big, we may not be able to get a proper seal with the mask. So we may not be able to ventilate adequately. So here is how you get the airway measurement. So it is basically by placing from the mouth till the angle of the mandible. So that is what we measure, and that is what we use. So coming on to nasopharyngeal airway. So the correct size nasal airway should always be chosen, because it has to reach from the how we measure is basically from the patient's nostril to the earlobe. So that is or the angle of the jaw. So that is usually when you say a little, maybe 2 to 4 centimeters longer than the oral airway. Why is it important to select? Sometimes we can see that certain people might go with the nostril size. It is very commonly seen in certain settings, because in that hurry, you might just want to put the tube inside, just like how you do want to put an NG tube. But that what will happen is we have all these turbinates and all the nasal concave which is sitting inside. So that is going to further reduce the space that is there. So that may not be, so if you just go by the nostril size, that may not be correct. So if nasal airway is not available and you want to go ahead and do a nasopharyngeal, nasopharyngeal, if you want to maintain with a nasopharyngeal airway, another option is to get a appropriate size ET tube, and it can be cut to appropriate length. And then that can also act as typical way to ventilate the child. So the problem with nasal airways is that they cause significant nosebleeds, especially when the children have hypertrophied adenoids. So they can become plugged adenoid tissue, which can be later be aspirated. And so it's very important that as we go into the nasal cavity with the nasal airway, it has to be very nicely lubricated. And also the other thing is we have to keep watching when the nasal airways in situ. You have to keep looking for any signs of pressure necrosis at the level of the nostrils. So that means if the outside itself is getting compressed, definitely the inside has to be worse. So there will be significant ischemic compression. So here we see the correct way to measure from the nostrils to the earlobe, or it can also be towards the angle of the mandible. So here you can actually ventilate the child with the bag and mask. So with the bag separately from the adapter in there, and you can actually close the child's other nostril and use a proper chin lift so that there can be a proper seal. Going on to adult advanced airway. So we have various techniques like endotracheal intubation, LMA, laryngeal mask airway, laryngeal tube, perilaryngeal airway, and finally we have surgical airway, cricothyroidotomy. So these two are most commonly used. So we will discuss more about them. So regarding in an emergency setting, we are always going to go for rapid sequence intubation. So what are the considerations? I'm not going to talk in depth about the breathing or the ventilation, that part. So what are the considerations that we do for a child when it comes to rapid sequence intubation? So as in any case, we have to pre-oxygenate minimum of 3 to 4 minutes. We have to reoxygenate with 100% oxygen, because there can be moments of hypoxia and apnea while trying to be intubating. So if you do not have good reserves, there can be immediate tissue hypoxia. And also there is a whole lot of vagal activation that is happening while the tube is being put in. Then there is adequate bagging. So appropriate mask size. So this is what is most and most important. Even now we had half an hour earlier in our own emergency. So the mask seal was not adequate. So we were not able to achieve correct saturations. So when we got the correct appropriate size mask and when the seal was correct, we were able to ventilate properly. So here the thing is, we measure the child's from the root of the nose to the chin. So the crease, chin crease, that is basically your length of the mask. So that is where your mask should be, and the seal should be adequate. And how do we get a proper seal is basically using the seal technique. So the thumb and the index finger is over the mask with the seal, and we are extending the jaw by causing some with the third finger. And in infant, what happens is there can be higher chances that we can compress the soft tissues of the neck with the fourth and fifth fingers. So it is very easily made mistake. So what we can do is just leave the fourth and fifth fingers free and just adjust the airway with just adjust the mandibular space with just the third finger. So what you can do is, this is very important, and so only the bony part of the mandible should be lifted and not the soft tissues along with it. So this is basically a table to say what is the appropriate size of the laryngoscopes, what is the type of laryngoscopes preferred, and the depth at which it has to be fixed, the ET tube, the size and the depth of ET tube. Most of you would be knowing, as the American Heart Association says. So we have the formula stage by 4 plus 4 for a uncuffed tube, and for cuffed tube it's 0.5 to 1 centimeter, 1 French lower. So that is what is used, and the length at which it is fixed is basically thrice the size of the ET tube. So if you have a 4 size tube, then you have to fix it not more than 12. So at 12, maybe keeping at 10, 11 would be much more better, because these are all approximated. Not every patient is the same. So you always, it's best to go with the vocal cord guide and to make sure and go by the clinical findings post intubation. So here we know there is a laryngoscope. So how to hold? So the correct grip is basically that, such that the forearm and the laryngoscope blade are aligned in the same line. So there is no point holding at the handle, and also the elbows also has to be facing anteriorly with the arm lying parallel to the body. And it is not, this kind of angulation will also not help. And always the movement has to happen at the level of the hand and not further in the, further inside the mouth. That causes more trauma. So here we can see that if we have this is an infant. So if there is a curved tube that is basically put into the airway. So what happens, it basically holds the epiglottis down. So that will cause the epiglottis per se will compress the airway. So that is what we don't want, which is why we want the straight tube, which can lift the epiglottis also along with it. Coming on to assessing the appropriateness of depth of the blade. So the best thing is to do is going on with the clinical view. So when you go in with, say, your laryngoscope blade, you're only seeing, most of the times, most of us tend to put an NG tube prior to intubation. So you see that the NG tube is there, and that mostly will go into the esophagus. So we are only seeing the esophagus, means we have gone beyond the airway and gone into the laryngopharynx. So what you can do is just retract the laryngoscope plate slowly till you can actually visualize the larynx. And if you're not gone enough, so you'll have to keep swiping the tongue slowly, and you'll have to go till you can see the airway, the vocal parts. So that is about the that statement. So regarding whether to choose cuffed tube or uncuffed tube in infants or toddlers, so there is strict recommendation that is more than 8 years, everybody prefers only cuffed tube. So why do we say that we cannot use cuffed tube in infants? Is because cuffed tubes basically once they put in, they are always one size smaller than the uncuffed tubes. So that means there's a smaller airway sitting in a already affected airway, which can be either obstructed, edematous, that can cause even more resistance to airflow. So there will be difficulty in ventilating this child. But however, if you use an uncuffed tubes, there can be more leak, and there can be more chances that this tube can get dislodged, especially when the child is ventilated for a longer time. And also there is a higher risk for aspirating in this child because there is more area that is free. And however, when it comes to say a neuroprotective intubation where you are thinking just 24 to 48 hours, you'll see the sensorium and remove or extubate. At that point, this might not make much of a difference. But however, wherever you are thinking that certain situations, you have to definitely go for cuffed TT tube, which is when there is a high risk for aspiration. Certain babies who are brought with bowel obstruction, surgical abdomen with abdomen distension like septic ileus and all those situations. When there is a poor lung compliance like in pneumonia, ARDS, scrub ARDS, when there is pneumoperitoneum, when there is extrinsic pressures coming from the lung, and precise control over ventilation is required. We want to carefully monitor every single PCO2 reading has to be, and that has to be monitored properly. So in those kind of settings, like we want to keep the PO2, PCO2 at definite range within a smaller therapeutic range, then that kind of situations like in raised ICP, single ventricular physiology, in all these situations, we usually use cuffed endotracheal tube. So what we have found is that in the recent findings, the cricoid ring, it's usually the previous thought is it is round, but now it is thought that it is more ellipsoid. So when it is ellipsoid, what happens is on the anteroposterior side, there is still chance that even if you put an uncuffed tube, that can still erode and cause pressure necrosis. So it is not really mandatory or that, you know, you have to be using an uncuffed tube. So now there is a more inclination to use low pressure type of cuffed tubes in even in infants and toddlers. So when we are using cuffed low pressure tubes, there are so many advantages, including better protection against aspiration, lesser times we'll have to keep changing the tube whenever there is prolonged ventilation. Also, it allows for higher ventilation pressures with even when the underlying lung has a poorer compliance, and it allows for more precise monitoring of the ventilation and provides more accurate tidal volume. And also the waste space is actually less. So the leak is quite less. So there is less release of these anesthetic gases into the environment. Also, there is decreased risk of fire in the OR room or in ICU when an ignition source is present. So coming on to now, we know that the correct size of the tube, correct size of the blade, how much to go in, all that. Now we have to see what are the medications. So in most of the times, one thing which we have to avoid is in newborns, they are very prone for bradycardia, mainly because bradycardia hypertension, especially because of reasons we have considered already, like decreased sympathetic tone, more predominant parasympathetic tone in them. So midazolam is best avoided in newborns. And also the thing is, like we said, there can be a shoulder roll which is kept for this round occiput. See, the round occiput, what happens is, if it is not stabilized appropriately, that occiput will keep rolling over the table. So that itself can cause significant issues with intubation. So you have to stabilize this occiput. Either the assistant can stabilize it, or even the person who is intubating, the other hand which is free, that hand can also be used to stabilize this occiput. So the depth of fixation of an ET tube, the best guide, as I said, is vocal cord guide. So the vocal cord guide, as all of you know, will be this particular black marking. So if you keep that at the level of the vocal cords, you're almost sure that you're not going to go too deep and not into the right main bronchus, cause further issues, atelectative damage, all that. So the displacement of this ET, what happens is a lot of times we may not have a ventilator readily available, especially in most of the ED settings. Also, there can be times when in times of mass outbreaks of these epidemics, we might run short of resources. So we'll have to depend on other things like manual like human power. So if somebody is bagging like that and not a ventilator, a fixed machine which is doing everything perfectly, there can be times that these things can slip. So the child can actually, somebody can push it further down into the right or the left main bronchus, or it can get dislodged out of the airway itself and can go into the esophagus, or it can be sitting coiled up in the mouth. So all these things are possible. So post intubation, it's very important that we get a proper like, a sooner shift to a ICU or a definitive setup. And also the person who's doing this bagging can also make sure that the tubes are not kinked. So that most of the time saves from all these kind of issues. So here, this is what I already explained. Sometimes the tube can go further down into the, it can go, if this is the level of the vocal cord, it can come up quite a bit if the head is being extended, or if the head is flexed, it can go further down into the right main bronchus or one of the bronchi. Also in infants, because all the structures are very smaller, most of the times we do have to give a cricoid pressure because we have to see the airway, which is more anteriorly placed. But when we give that cricoid pressure, it has to be quite gentle, especially because the cricoid becomes the place which is extremely narrow in a pediatric airway. And having said that, cricoid pressure has to be given in all cases where you have high risk of aspiration, like in case of an unconscious child, or somebody you have to intubate sooner because of an anaphylaxis, who's had a recent meal, etc. Coming on to the laryngeal mask airway. So laryngeal mask airway is a supraglottic airway. It stays above the level of the vocal cords, and the advantages is that it is less stimulating, less traumatic, and it's easier than intubation. But the thing is, we'll have to use the correct size LMA, and if used appropriately, this is the best for like short-term ventilation, daycare procedures in OT, things like that. And for difficult attempts of LMA, usually you just have to slide it along the axis of the oral airway. So, but if there is any difficulty, like in case of, say, if there is a tongue which is obstructing, if there are big kissing type tonsils or something, what you can do is you can slide it laterally, and once it is in, you can rotate it back to the midline. That's also possible. The disadvantages with this is that it doesn't protect from any kind of aspiration. Laryngospasm is still possible. And always when somebody is being intubated, being maintained with the LMA, definite airway by means of ET has to be, like an endotracheal tube has to be kept as a backup. It can always slip, especially in babies, that is quite common. So it has to be kept as a backup. So this is just a table showing the correct size of LMA. So what are the difficult airways now? So when you call something like, this is the last topic. So difficult airway can be anatomically difficult, or it can be a normal airway, but because of the other factors, it becomes like a physiologically difficult, like a functionally difficult airway. So what are the anatomically difficult airways? Like an airway which is edematous, or there is an airway where there is significant bleeding, like pulmonary edema, where there is a lot of frothy blood and sputum, everything pouring out. So those are all difficult things like that. And also when you have some facial anomalies, facial asymmetry, like in case of Treacher Collins syndrome, or there is like a chin that is very short and hypoplastic. So you have something like retronathia. So that is, there is mandibular hypoplasia, like in Peary-Robbins syndrome, or it can be limited opening of the mouth when there is post, say, some burn, some contractures, trismus, things like that. Or there is limited range of motion of the neck. So especially when there are certain external masses which is basically compressing, they can literally limit the neck motions. Then the other thing is macroglossia, poor visibility of the uvula. Extreme obesity can cause very short necks because of the padding of the fat pad. And the other thing is they can also have significant double chin. So there is history of sleep apnea that can also very common in case of obese kids. Also, there is a larynx which is fixed to the midline by means of a tumor, scar, like I said, a neck mass, any vocal cord abnormalities, or certain cases like mucopolysaccharidosis, where there is so much crowding of the teeth, all the structures there are quite edematous and like macroglossia, gum hypertrophy, so many things are there. So these are the kind of difficult airways when you just look at them as anatomically. So this is just a picture showing a child, a neonate who's born with cystic hygroma, and somebody with, say, retronathia, like in case of a Peary-Robbins syndrome. What is physiologically difficult airway? The airway anatomically might not be difficult, but however, in certain cases, the intubation becomes extremely difficult, mainly because of higher chances of arrest in this child, hypotension and arrest. So these are conditions like as in shock, even with compensated shock also this is possible. With already existing metabolic acidosis, like in kids with IEM decompensation or a DKA, things like that. And also there is, once a child has already had a cardiac arrest, the perfusion status, as you know, would actually be poor. So they are also more prone for metabolic acidosis, and they will also be having shock. So these are the kind of situations where you have physiologically difficult airway. So in such an airway, what are the tips for a successful intubation? You have to avoid or correct this hypotension, which is, if it is pre-existent, you have to correct. So you have to fill them with saline boluses, mostly like 10 ml per kg. That is what is recommended now. And also better to load adrenaline infusion prior to intubating if you're thinking that that will kind of keep your cardiac activity better. And also drugs like midazolam, which can cause profound hypertension, has to be avoided. So when you are not using, say, midas, like, you can use either, we will all be using either midazolam with ketamine, fentanyl with ketamine, things like that. So if you're not using midazolam, maybe an extra dose of ketamine, the other drug can be used. And always correct the acidosis, give a bicarbonate bolus. And definitely we have to anticipate that this child may go into a cardiac arrest. So keep the arrest medications, especially adrenaline, that is 1:10,000 adrenaline preloaded. Always alert the advanced airway team. And so in most of our hospitals, it may be a panel of anesthesiologists, ENT surgeons, and also maybe pediatric surgeons for surgical airway. So they have to be kept in alert that there is a child who is like this being intubated like that. So somebody who is free at that point, who's not in the scene with the team, can actually be alerting them, so that in case if we end up with a difficult airway, we may be able to get help sooner. So as I said, the difficult airway is when you're not able to either say intubate, or you're not able to even sometimes we may not be even able to oxygenate them, like not even able to ventilate them. So that's the correct thing. So we may not be able to ventilate even with bag and mask. We may not be able to get the adequate, like in case of pulmonary edema, so much extra PEEP is required. So these are the conditions like that. Then what are the various ways that we can use, alternatives that we can try when you think that your routine rapid sequence intubation may fail? So that is when you can use stillet and try guiding the tube in. Another alternative is using a bougie airway, or we can take the child to theater like a direct laryngoscopy done in the theater with all calm environment, anesthetist, everybody, surgeon, all of them at the backup. So, for example, in cases like, say, in our hospital, we do this routinely for kids with diphtheria, and this was always advised in the earlier very common case of epiglottitis. Also, we can use lighted stillet, which can actually, the stillets can show you the way how to proceed further. And you can also use intubating LMAs. Through the LMAs, you can actually slide the tube in. And we can also use fiber optic flexible scopes, Bullard scopes, video laryngoscopy. And finally, maybe we might have to even do a surgical airway, which is cricothyroidotomy. Dr. Santosh, can I proceed further?
Yes, sir. You can continue. Just
Yeah,
a
thank
very
you, sir.
interesting class we had. So please.
So now we just want to re-emphasize. I'm done with almost all my topics per se. I would like to make it more interesting with the participants who have joined. If they can reply, you can unmute yourself and reply. So we just go to certain scenarios. So first scenario is a 2-year-old boy who presented today, this evening, with the history of fever since yesterday night and some history of seizures 15 minutes prior to arrival to the ED. And the seizures, they are characterized as uprolling of eyeballs with some convulsions lasting just 5 minutes. Following which the seizures are stopped without any medication, but however, they say that the child has been excessively sleepy, like a post-ictal state. So when you assess the child here, you've seen that the temperature is 102, like he's got a high-grade fever, he's drowsy, but he is arousable to call. But again, once the stimulus is over, he again goes back to sleep. And heart rate is 146. Maybe this is proportionate to the fever, not really in a shock status. Perfusion is otherwise good. And he's got some mild distress, but that also adjusted to the temperature may be normal. But only thing that is worrying us and also the parents is that this child is making on a snoring kind of sound. And saturation is only 90% with room air. And with oxygen via NRM, this is only improved to 92%. So how would you approach such a case? Can somebody tell me? Hello?
Yeah, many don't have the unmute option. So someone has typed in upper airway obstruction, can use oral or nasal airway.
Yeah. So here the thing is, the trick here is that that's perfectly correct. Only thing is, we may not even need to do something like an oral or a nasal airway. Here the child is just too knocked out after, maybe it can be just a medication which they have loaded, the seizure anti-epileptic medication, or just a post-ictal state. He is just too out. So this tongue is just fallen back. So you just have to keep the child in left lateral position, and we see that the saturation has already come up to 98%, and he doesn't require any oxygen. And once the child is awake, everything seems to be settled. Okay, this is the second case. So a 2-year-old boy with dyskinetic cerebral palsy with oromotor and swallowing dysfunction. So he was brought with 2 days history of wet sounding cough, cold coryza, and he's also got high-grade fever for 2 days. And he's also got fast breathing for a day, poor oral intake, and lethargy. So on examination, he's got some low-grade fever. He's got some gurgling sounds in the airway. He's in mild distress with extensive conducted sounds, which is heard bilaterally on auscultation. Hemodynamically stable. So what is the airway management that is indicated in this child? And what to do if this does not settle with the immediate management? You have to see the child as a whole and then answer. Sir, in the chat box.
Start with basic maneuvers as per one answer.
So here we know that already this child has increased propensity to have secretions. So he has got an oromotor dysfunction, swallowing dysfunction. So the chance that he is always drooling is there in the background. And now this child's general condition is quite poor. So he's not able to maintain the airway because otherwise whatever that little bit he would have swallowed is all pooling inside his mouth. So all that you can do now is maybe give some suction. Okay, so we can suction out that. And in case if the suctioning frequently does not help and his condition continues to deteriorate, I would suggest this child requires a definite airway. It might not just settle with oropharyngeal airway, because it all depends on the overall situation of the family also. Somebody might just opt to say, we did not go all out. We doesn't want a very invasive care. They might say that we just need some comfort care. Maybe then manage with the oropharyngeal. But somebody who wants to go all out for this child, the best thing to do would be, again, ventilate. If suctioning alone is not enough. Okay, this is the third case. This is a 2-year-old girl who was brought with low-grade fever, cold, cough for 2 days with no distress or any lethargy. She prefers to eat only liquid food, and parents are worried about a barking type of sound with every time she cries. And there is a baseline hoarse inspiratory sound. So there is stridor on examination. Otherwise, she is quite stable, no distress, and she is vitals wise stable. So what is this condition?
We got
Hello?
answers saying group.
Yeah, so the condition is group. What's the common organism? The common organism is usually viral. So the imaging finding, as we have already mentioned before, is a steeple sign. So the idea here is that this is a child who doesn't have fever, just a playful child who just has that stridor. So mostly looking like a viral etiology. And mostly it is para-influenza virus. Having said that, RSV, adenovirus, paramyxovirus, metapneumovirus, all of them can also cause croup. The closest differential to a croup would be a laryngotracheobronchitis, which is caused by bacteria per se. But these children presents usually with high-grade fever. So the common organism to do that is Haemophilus influenza. So this is a steeple sign. There is a significant airway narrowing. And so that is the steeple. It looks like the church tower. So that is why the name came. So here we have a 1-year-old girl who's not vaccinated since birth. She was brought to ED with fever for 2 days, high grade 104, which is associated with cough, noisy breathing, fast breathing, and excessive drooling of saliva for 1 day. And she appears to be febrile, toxic, with stridor and drooling of secretions noted with significant respiratory distress. So on auscultation, we are only able to make out that stridor and some extra conducted sounds. So the etiology here would be
Someone
there's
says
something which we do not
epiglottitis.
see.
I don't
Yeah,
know.
so we do not see epiglottitis quite commonly nowadays because there is routine vaccination for Hib vaccine. So it's basically incorporated into the universal immunization schedule in most of our Indian states. So the pentavalent vaccine has the Hib vaccine. But this girl sadly was not immunized. So definitely this is epiglottitis. And the airway management, as we have discussed earlier, this is a child who can suddenly deteriorate by, if you touch her, somewhere you're going to trickle inside the oral cavity. She can deteriorate because of extensive laryngospasm. With such bad airway edema, we might not be able to do anything at that point. So the best thing is to get her to a calm setup where you can get an advanced airway. So that can be done either in an ICU setup or an OR, and definitely give her oxygen that can cause some bit of relief to the hypoxia unless the child is distressed about the mask sitting over her face, and calm the child. And definitely here adrenaline or nebulized adrenaline, what we have given crew, or say oral steroids or IV steroids, that and all is not shown any benefit in case of epiglottitis. So here you'll have to give them antibiotics, and previously the drug of choice used to be ampicillin, but our advice would be not to just prescribe ampicillin, because about 40 to 50% of our Haemophilus now is ampicillin resistant. So start with amoxiclav, cefuroxime, ceftriaxone, cefepime, or even maybe you'll require meropenem. And the imaging finding is a thumb-shaped epiglottis because of the significant airway edema. You can see that there is hardly any airway that is left there. Here we have a 11-month-old infant with history of sudden onset of respiratory distress since today afternoon. There is no history of any premorbid illness or URI symptoms or fever. She is alert, afebrile. Heart rate seems to be a little on the higher side, but otherwise perfusion status normal. Maybe it's because of the cry. And blood pressure, everything is maintaining. But however, has severe distress, suprasternal retraction, saturation on room air is just borderline. And on examination, there is some decreased air entry on the right side. And also there is some right-sided V's. Can somebody tell me if there is anything else from the history that you would like to know?
Many have guessed it as foreign body.
Correct. So the history is what you'll ask us if there is any history of foreign body aspiration. So this boy had some groundnut ingestion yesterday evening. He just took it out of curiosity from his brother's plate and had some cough, which the mother ignored at that point. So now it's causing its effects. So when you suspect foreign bodies, when you have unilateral findings and the sudden history, that dramatic sudden history with nothing in like a premorbid illness is there. So that is when we suspect foreign body. Achieving which developmental milestone predisposes to a foreign body aspiration in infant? Can somebody tell this? We don't see children coming with foreign body at 6 months, 4 months, 5 months. But then somebody starts coming like say 7 months, 8 months. So okay, this is a little into pediatrics. This is pincer grasp. So the child starts picking up everything, whatever he is getting, and he starts putting it into his mouth. So there's a 1-year-old girl with GERD, gastroesophageal reflux disease, failure to thrive, and recurrent lower respiratory tract infections. So far, in this 1 year of age, she's had 4 times inpatient admission, which needed IV fluids, oxygen, nebulizations. And she was brought currently with some noisy breathing and progressively getting worse for a week. This noisy breathing has been progressively worsening. There is no fever, poor feeding, lethargy, or any URI symptoms or distress. So the last admission for this LRI was 1 month ago when she was in ICU for about 10 days. And she was also overall hospitalized for 2 weeks. And only some 1 week she's remained well, after which she started developing this noisy breathing and she's got stridor. Any more specific history somebody would want to know? To reach at a diagnosis.
Vaccination, congenital heart disease, they are the guesses.
No. So this is a child who's got some recurrent LRI and she was hospitalized. She was in the ICU. So this is probably a subglottic stenosis. So what I would probably ask is, was a child ventilated? So this child was ventilated in ICU for about a week and after that has developed post-intubation subglottic stenosis. A 6-week-old baby boy gaining weight adequately on exclusive breastfeeds came with complaints of progressively worsening stridor since 2 weeks. And mother feels he has been having similar but maybe a milder noise since about 2 weeks of life. But they were not really worried at that point. So there is no findings except for some mild stridor. And you've seen that over the hours of emergency stay. Whenever he's sleepy, this stridor is worse. And also whenever he's lying flat on his head, again, this is worse. So anybody diagnosis?
Laryngomalacia, that's the answer.
So definitely a floppy epiglottis. It basically gets more, it can become, it obstructs the airway more whenever the child is sleepy. A 4-month-old boy born preterm at 34 weeks, NICU stay for about 10 days for weight gain alone. Otherwise, cried at birth, no neonatal issues, no jaundice, sepsis, distress. And this child has also been having steady weight gain, currently only on breastfeeds. It's been brought with cold coryza for a week, breathing difficulty on and off for 3 days. He is continuing to be feeding well, except during these episodes of cold and breathing difficulty. Mother says he is otherwise active. He's afebrile, playful when you saw, hemodynamically stable, has some mild respiratory distress, and there is some wheeze and conducted sounds heard bilaterally scattered on auscultation. He's got 3 centimeter liver palpable, no other signs of cardiac failure. Diagnosis.
Someone says bronchiolitis.
Correct. So bronchiolitis is mainly viral. Most commonly it's RSV. And the risk factor is that this child was a preterm child. So usually children with congenital heart disease and preterm children, these are the ones who predominantly get bronchiolitis. And the sad thing is in their course of life also, the bronchiolitis takes a longer course to recover. So this is the last case for the day. It's an 8-year-old boy with cough and breathing difficulty since night. No history of fever or poor oral intake. He's been having similar illnesses in the winter season and had it really bad after a sports day last year. It responds quickly to some nebulization given at local clinic. He also has seafood allergy, and his paternal and maternal uncles, both side uncles, also have similar complaints in their childhood, and both of them are still taking some sort of inhaler. Paternal grandmother was treated for TB 15 years ago, however, has been asymptomatic after treatment. Examination-wise, he's afebrile, alert, stable, but has significant distress with absent air entry bilaterally, and currently there is no wheeze for. So what is the diagnosis? Here, I've already mentioned. So this is very clear that this is a childhood asthma with severe obstruction. So this child at this stage with this bad, this thing is almost near like a silent chest. So he would definitely need IV steroids to tackle the inflammation sooner, nebulized salbutamol, nebulized budesonide, oxygen therapy, IV fluids, all supportive care. And he might also require more intensive care like subcutaneous adrenaline or Maxelf. Maybe he might even need ICU stay, terbutaline infusion, all that. So these are just some spotters which are pediatric specific that, good to know when you have a difficult airway. This is the child. Somebody wants to take a guess. It's already written there. It's Peary-Robin sequence. So whenever you have Peary-Robin sequence, it's a sequence. So where there is a hypoplasia of the mandible, that causes your oral cavity to be small, the tongue is big, that basically doesn't let the approximation of the palate happen. So they usually have a cleft lip, cleft palate. So this is usually the scenario. This child, somebody, if you see this child has multiple anomalies, there are some ear tags, ear anomalies bilaterally, there is some facial asymmetry. Looks like he's also got some sort of his jaw on the right side is not very apparent. He's also got lag of palmos. So many issues. So this is Fletcher-Collins syndrome. Everybody would know. Diagnosis. Hello?
Yeah, we have answers. Downs.
Downs, yeah. So what are the airway issues with Downs? Quite a bit actually. They also can have other congenital anomalies. They can have cardiac issues which can complicate as a physiologically difficult airway. Most of these Down children, they have a large tongue. So macroglossia is quite prominent. That can make intubation difficult. Also, the thing is they are having very lax ligaments of the neck. And that causes, if the head is hyperextended, can cause atlantoaxial dislocation. And that is one of the most common reason for extremely early mortality in case of Downs. So these are the things. And also, that all their laryngeal muscles, everything will be very floppy in view of their general hypotonic state. This one, anybody? It's a little complicated, but clues. There's a baby here who's got probably a protruding tongue. Same thing here, some umbilical hernia, child who is quite like a macrosomic child with tongue protruding. Again, has got some sort of abdominal wall hernia, macroglossia. This child also has got an abdominal wall defect, ear anomalies. Anybody? Hello?
Yeah, no answers yet.
Okay. This is Beckwith-Wiedemann syndrome. Here again, the implication for your airway is macroglossia. This is just a picture. Any differentials you can say?
Cystic hygroma is, we have a couple of answers.
Correct. So this can actually be cystic hygroma. But with that lobulated appearance, maybe even should think of a teratoma unless you would comment with an imaging, you may not be able to say some sort of external mass which compresses our airway. So these are all extremely challenging situations where you would need somebody of an expert opinion to do this. So we would definitely not do unless a child is like, extremely sick, we may not be able to intubate them on a routine basis in an emergency. These kind of children will definitely require more intensive monitoring, more intensive inputs. So that's all. Thank you.
Thank you, Dr. Jovin, Chris. It's a very good session. We had a nice discussion. I hope our residents won't run from pediatric cases from now. Doctor, before closing, we had a few questions from our residents. One of the questions is that irrespective of age group, which ET tube do you prefer, cuffed or uncuffed? One thing to remember, I think.
Sir, it would be cuffed, but then if you are thinking that, it's an infant, it's better to do uncuffed also.
Okay.
But always cuff tube is nowadays preferred.
Yeah. Preferred is cuffed. Okay. Okay, doctor. Another question is one of our residents had asked that in case of foreign body in trachea, how are we going to manage airway obstruction, foreign body in trachea?
So something which has gone beyond your vocal cords and it is there in the trachea right now, that means definitely require an upfront bronchoscopy. So this is not something that is going to just come out with your back slaps or abdomen thrust. That is not going to improve. So once it is gone beyond the vocal cords, it is going to sit at either at the cricoid, it is going to go maybe even beyond if the slit is in alignment with the cricoid alignment. So if then definitely it is going to more and more irritate the airway mucosa. So at that point, more and more laryngospasm. So anything that is going to retrieve from an ED may not be correct. So the best thing would be to do, take the child immediately, rush to theater. We've had quite a bit of cases like this menthol cap ingestion is what we see quite commonly in our ED. So we involve the anesthetist, surgeons, everybody. We rush the children and then we intubate them there and they do a bronchoscopy and then they take it out.
Yeah, thank you, Dr. Jovin. It's a very nice discussion. We thank you on behalf of our Yashoda management and Dr. Srinath for joining with us. And now I take this opportunity to thank our Yashoda management, Dr. Srinath, Dr. Vinith, Dr. Naveen, Dr. Ranjith, and Dr. Kiran Varma for presenting sessions which are very useful sessions for the residents who are in various groups, various parts of the country who can easily access to these sessions and they can share their knowledge. Thank you, Dr. Jovin. Thanks for joining us.
Thank you.
And thanks to your team for.
Hello. Special thanks to Dr. Srinath and the SEMI platform for giving me this opportunity. Also to my HOD, Dr. Debashish, who was given all this knowledge for us, whatever we know is because of him. So special
thanks to your team for allowing you to stay in a quiet environment in a busy ED.
Thank you very much, Dr. Srinath here. Thank you very much.
Thank you, sir. Can we leave, sir?
Yes, please.
Yeah, thank you.